Hi everyone, good evening. I'd like to welcome you all to our Facebook Live event this evening. Thank you for joining me for the next 30 to 45 minutes. I'll be hosting today's event, which is on the misunderstandings of miscarriage. It is a very important topic of discussion, and I think it's time we facilitate communication with regards to everything surrounding pregnancy, loss, and miscarriage. And I'm here to answer any questions that you might have, as well as, help talk through any points of interest. Now, hi Jack, welcome. That was one of our first comments. Hi Kelly, and I particularly wanted to mention that October is Pregnancy and Infant Loss Awareness Month. And today, the 15th of October in particular, is Pregnancy and Infant Loss Remembrance Day. So it is a very important day, and I would like to take a moment to acknowledge any of you out there who are trying or who have suffered a loss. So just in a way of introduction, my name is Dr Manny Mangat, and I am a CREI or reproductive endocrinologist and infertility specialist. I'm the clinical director of our City and Burwood service and practice out of Greenwich as well. So a lot of you may have heard of me or met me, and let's make tonight as informative and supportive as you'd like it to be. Now, hello to everyone who's come on. That's amazing. I would just like to say that we have also made a movie recently with the wonderful Tahina McManus, which some of you may have seen. It was introduced on 60 Minutes a couple of weeks ago, where they interviewed me briefly, and it is also now featured on Stan. So I think it covers a lot of important topics, and a number of very brave men and women have actually told their stories in that movie. So it's not only touching, but it's also informative, and it also, I think, sets the scene to allow people to discuss their experiences, as well as allows us as clinicians to understand how we can support our patients, as well as maybe look at how we can do things differently or better surrounding some of the clinical terminology used. We have also released a set of 4 videos covering the different aspects of miscarriage, as well as support, the myths, and the counselling around it. And the video on support has been released today, which you can find on our Facebook page. That is also a valuable resource that we have produced for Virtus Health. We have lots of little messages of hello. Hi everyone, thank you so much for joining me. So just to start, I'll keep talking a little bit, I suppose, until we have a few questions come through. And miscarriage is defined as pregnancy loss that occurs before 20 weeks gestation, and it can be divided into early miscarriage and later miscarriage. Now, early miscarriage is pregnancy loss that happens in the first 12 weeks of pregnancy. Now, unfortunately, miscarriage is really a lot more common than we think, and sometimes these early pregnancy losses don't even get to a pregnancy test. It may just be a delayed period. So for those that get to testing and then even ultrasound, the rate of miscarriage in the community is somewhere around 1 in 4 pregnancies. So if you have gone through a pregnancy loss, you are not alone. It is a common occurrence, and unfortunately, largely early first trimester losses are caused by abnormalities in the genetics or the chromosomes of the embryo. So we are made up of 46 chromosomes, XX for a woman, and XY for a man. And our eggs have 23 chromosomes, sperm has 23, and these chromosomes have to come together. They then have to recombine and double and divide before they make a new embryo. So it's amazing the processes that the embryo has to go through. So with regards to then the errors that can occur in that is what causes these genetic problems. And that is what actually, is the largest cause of miscarriage in the first 12 weeks. What's important to know is that you are usually not in control of those genetic errors and therefore can't do much to have prevented it or couldn't have done much to cause it. Because once those embryos implant, they're robust. Now we're starting to have a few questions. I've got a question here from Liz. And Liz asks, I would like to know what are the main causes of blighted ovum? Is it just mainly bad luck? And can a blighted ovum still happen in IVF even if the embryo passed PGD? Now, and the next question is about explaining what a chemical pregnancy is. So these first two questions already bring up the fact that a lot of the terminology we use is very clinical and confusing and outdated and almost irrelevant to what is actually happening in the pregnancy. And it's a huge discordance between what terminology or complicated words we are using and actually validating what the patient is going through. So to explain a blighted ovum, thankfully that's an old term and it's not utilized very often anymore, although the newer term is still very clinical and is called anembryonic pregnancy. So what that means is that the embryo has started to communicate and implant into the uterus, and it has therefore formed a gestational sac or a pregnancy sac. However, the baby and the other structures within the sac have failed to form. So when you get to your early pregnancy scan, you see implantation. However, there is no baby growing inside that gestational sac. So again, a blighted ovum then is classified as an early pregnancy loss. It is usually a loss that happens prior to 12 weeks gestation. And a lot of the time, this is also largely explained by a chromosomal issue in the embryo. So a genetic error that has caused the embryo to stop progressing in its development. Because the job of our uterus or endometrium is quite remarkable, and it realizes that that pregnancy will not make it to term, and therefore the pregnancy stops. So if an embryo has gone through PGD or genetic testing, and PGD is where we take a few cells out of the trophectoderm or the outer ring of the blastocyst, that is the area of embryo that will implant, and we test those cells for the genetics in the embryo. And if that comes back showing normal chromosomes, then Liz is quite right that we then shouldn't have pregnancy failure secondary to a chromosomal problem, because you would assume that the PGD has checked that. First thing to note is that PGD is about 99% accurate. So in 1% of the time, the embryo could still have a Mosaic error that can still contribute to its failing. And the second thing to note is that there are other causes for implantation failure as well that is besides the embryo. So if you've done IVF and you've got an embryo that's chromosomally normal, it's not Mosaic, the chromosomes are fine, then it could be things like a large fibroid that is growing into the uterus, or a structural problem with the lining, a septum in the uterus, multiple large polyps that affect blood supply to the lining. Some people have clotting issues, and thrombophilus can affect the way embryos implant. And of course, there's the more controversial area of immune fertility or immune miscarriage medicine, where there's a lot to learn in that field. We're still researching a lot of things to do with killer cells that you may have heard of, or other immune causes. And a small percentage of the time that can be playing a part with the implantation, and therefore a blighted ovum could still happen even if the embryo passed the PGT test, Liz. And Julie, with regards to what a chemical pregnancy is, again, the term chemical or biochemical is used to explain that there is HCG hormone detected in the blood, and that happens when the embryo has formed a blood supply with the endometrium and commenced a relationship with your uterus, and therefore after implantation the embryo starts to produce the hormone called HCG. Now once that is detected in the blood, that means a pregnancy is starting to occur. The pregnancy has to progress till about 5.5, 6 weeks gestation before we can see anything on ultrasound. However, sometimes people get a delayed period, so you then go and do a home pregnancy test and it comes back positive, or you see your GP and you do a level and that shows pregnancy hormone. However, a few days later you start bleeding. Then that is classified as a chemical pregnancy if the levels then start to drop. So the levels then start to drop to negative. So what that indicates is that pregnancy did occur. The embryo did start to implant, and it has then decided that it was no good to continue. Hope that answers your question, Julie. Hi, Carmony. Welcome. Thanks for joining us this evening. I think so far I'm up to date with our questions. Oh, hi, Rainbow. I have another question here, just as I was about to start launching into discussion of a few other things. Rainbow has a question here. Is grade 3AA a good quality embryo? So let me answer that first. So grading of an embryo is based on the Gardner's grading criteria, and that is the most commonly used criteria worldwide. Basically, the number, so 1 to 6, is showing the stage of the blastocyst. So 1 is very early, 2 is early, 3 is a blastocyst, 4 is expanded, 5 is hatching, and 6 is fully hatched. So a 3 is a blastocyst. So that's where it should be on day 5. The letter, you have 2 letters after the number, and the first letter represents the inner cell mass, which are the cells that become the baby. The second letter represents the trophectoderm, which are the cells that become the placenta. And there's one of 3 letters. So A is pretty much perfect. Any little blemish or fragment puts it into B. So B's are still really good embryos. And if there's a paucity of cells, or they're fragmented or irregular, or there aren't many of them, then the embryo gets a C grade. So if it's a 3AA, morphologically, by appearance, it is a good quality embryo. However, remember, if that embryo has not been genetically tested, we don't know if its chromosomes are normal or not. And a good-looking embryo may still have an abnormal complement of chromosomes within it. So the next part of the question says, when a pregnant woman reaches 6 weeks pregnancy, have they surpassed chemical pregnancies? Well, Rainbow, yes. If you have made it to 6 weeks and made it to an ultrasound that shows a pregnancy sac, then you've moved on to the next stage. If there's no baby in the sac, then it's called anembryonic pregnancy. But if you can then see a yolk sac and a fetus and a heartbeat, then yes, you have definitely surpassed the chemical stage. I'm so sorry to hear that you've had a few chemical pregnancies before, but let's focus on that for a second. If pregnancy is occurring, even if you've had a loss, it shows that the sperm and egg are communicating and the embryo is trying to communicate with the uterus. I know it sounds like a negative, but yes, it is a loss, but hang on to that hope that if we've got you there, we can probably look at different causes as to why there could have been a chemical pregnancy, whether it's from the embryo side of things, or whether it's from the body, or whether it's from the sperm quality, or whether it's from implantation, or whether it's from immunity, and hopefully line everything up for you and get you that successful outcome. So we usually say women who have gotten to a point of a positive pregnancy usually have a good prognosis to keep going and get to the end. So I hope that keeps you focused. Kelly's asking, is there anything I can do to prevent a miscarriage? Now, Kelly, that's an excellent question. You know, as soon as a miscarriage occurs, I think miscarriage itself has such negative connotations, which is what we need to break through. The word miscarriage itself almost implies like a mistake in the carrying. And as a woman, you feel that inherently your body is built to carry a pregnancy. And so when that pregnancy fails, the first thing you do is, ask yourself why. And the next thing you do is say, what did I do to cause it? It's so common to go immediately into shame and blame and guilt and blame yourself, make yourself believe that there could be something you could have done or not done. So firstly, to answer Kelly's question, as I said previously, that in early pregnancy loss or loss that occurs in the first trimester, there is almost nothing you can do to disrupt that pregnancy. So having that one mistaken glass of alcohol before you found out you were pregnant, or doing your usual exercise, which is running 2 kilometers around the block, or as Kath is asking, is yoga safe throughout the IVF cycle and pregnancy? Yes, if that's what you're used to, absolutely. None of those things that you've done is actually going to cause a miscarriage. As I say in the movie, once that embryo implant, those critters are really robust and they hang on, and there's not much you can do to prevent that or to, stop it from keeping on going normally. A few things around that though. So we do say that obviously no excessive drinking, no smoking, because that lifestyle measures, the healthier you are, the better it is for the pregnancy. And we also say that in early pregnancy, try not to overheat because the embryo is heat sensitive. So no overheating, therefore don't go to a sauna or soak in a very hot tub. And therefore, Kath, to answer your question, yoga is perfectly safe, but just don't do Bikram yoga where you're going to be overheating in the first trimester. So they are the kind of things, that you can do to help yourself prepare for a pregnancy. But as I said, that extra run, that extra walk, the funny yoga pose, none of that is going to have been the cause for the miscarriage. Now, if the embryo has already decided that it's abnormal and your body has decided that this is one it's going to reject, there is then nothing you can do to prevent it. I hope that answers your question, Kelly. Now, Kath, just a little bit more about, not just about yoga, but I get the question a lot as to whether exercise is safe in pregnancy and your IVF cycle, and whether heavy lifting is safe. So let's go back a step to the IVF cycle itself. When you're doing IVF, you're taking medications to form more follicles in the ovaries, and therefore towards egg collection, the ovaries get quite big and heavy. So we usually say that any high intensity, high impact exercise may actually give you some abdominal discomfort. And we also don't want the ovaries to taut. So high intensity impact exercise, maybe not towards the end, towards egg collection, and then a couple of days after that to recover. Once you're pregnant, you can gently go back to exercise that you are used to. So if you always walk 10 kilometers, then go ahead and do that. Maybe just moderate your pace. If you run marathons, maybe put that off for the first 12 weeks. But if I don't normally run a marathon, then I certainly shouldn't do that in the first trimester. So this is what I mean. Exercise in moderation is safe if that is what you are used to. Hi, Nicole. Welcome. I've got a message here from Sonia. And Sonia is asking if herbal medicines interfere with IVF injections. Very good question, Sonia. A lot of our patients take a holistic approach. So, we always say that obviously egg quality and sperm quality contributes to embryo quality and therefore risk of miscarriage. So with regards to egg the biggest determinant of quality in our eggs is our age, and that is somewhat beyond our control. But obviously we can have a good lifestyle, we can take antioxidants, we can take certain supplements, and some people see acupuncturists or take herbs to help strengthen their general hormone profile and to help reduce their reactive oxidative damage in their cells, and that's all fine. But if you are going to take herbs, some herbs have phytoestrogens where they do interfere with the way the body responds to medications, and if that's the case, just make sure that your herbalist is well aware of the process of assisted reproduction that you're utilizing and at which stage of treatment you're at, so that they can then alter those herbs to not interfere. If they are uncertain, the safest thing to do is to take the herbs in the preparation or lead up phase, but then stop those herbs when you actually start the IVF injections. Rebecca has a question on what would prompt a DNA fragmentation sperm test, trying to work out if we need to do one given sperm seems good. 1 failed transfer, and out of 16 eggs, 8 fertilized via ICSI, but only 1 5AA made it to the failed transfer. So Rebecca, there are a few good questions in that. And I guess the first thing is, let's talk about men. So far we have, as I said, focused on us, right? That it's miscarriage, it's we feel like we failed. You know, what can we do to change it? Is there something that we did to prevent it? But it's very important to remember that there is a male partner in all of this, and often they feel on the outer. So even though we're grieving and it's raw for us and it's happening to us, it is very important to remember that a lot of this clinical explanation and terminology doesn't actually validate the emotions the patient's going through, let alone what the partner might be feeling. There is this discordance in how we explain things and how our patients and how all of you deal with it and perceive what's going on. This is where things have to change. I believe at any point where there's a loss, whether it's an embryo or a fetus or a later miscarriage, a couple together needs to validate that loss, grief, get counseling, and get the support that they need. So coming back to the male partner, who's very important in all of this, they're often sitting there quite alone going, did I do something? How can I help? And they feel so pained watching their partner go through the miscarriage, not knowing what to say or how to say it or what to do, because, you know, they kind of, as you said, are not in it and they're feeling on the outer. So one thing is support each other. The next thing is put yourselves in your best health. And we always focus on a woman and her eggs and her egg quality and her age. But reality is, new studies are showing that advanced paternal age makes a difference too. So in the past, we used to have studies that showed men who are over 55 had sperm that may have increased risk of, or errors in the sperm that increase the risk of bipolar and autism in children. There are studies now that show that men as young as 45 have started to see degeneration in their sperm quality and therefore contribute to increased risk of miscarriage. So to answer the question about how do we know or find out about sperm quality, that's also a tricky question, because the semen analysis that you do basically just looks at volume, concentration, movement, shapes, doesn't really tell you about the sperm function or the sperm quality. So the DNA fragmentation test that Rebecca is mentioning is where we look at the breaks in the sperm, and the more breaks there are, the poorer the quality. Therefore, the higher the percentage of fragmentation, the poorer the sperm quality. And that has been correlated to poorer outcome. So I think, you know, it's a valid test, Rebecca, but the fact is you've had 1 failed transfer, so stay positive. You had 16 eggs collected. I don't know how many of those were mature because immature eggs don't fertilize. And then of those 8 fertilized, and I don't know the reason that we did ICSI, so there's a few things there that, you know, I can't give you specific answers for, but, you know, why we did IVF over ICSI, didn't do IVF over ICSI, and of those, out of 8, you may have expected 3 or 4 to make it to blastocyst, but then again, their quality could have been variable. So to get a 5AA blast is a very, very good start. So I guess the question then is, were the chromosomes in that embryo normal? I don't know your age because the percentage of normal embryos depends on your age. So there are a few questions to answer there. But the fact is you made an amazing embryo, you've had one failed transfer. Please stay positive. You will probably get there. You just have to have someone sit down and go through all those nitty-gritty things that I said, and probably no harm in getting your partner to contribute and do a DNA fragmentation, and he can join in healthy living and, you know, taking antioxidants and helping his sperm quality. Kath, you then ask, is road cycling a bad sport for males? Now, that's a common question I get asked. And why is that? Because there are some studies out there that show that cyclists wear lycra and they sit on their testicles, on their bicycles for long periods of time. And therefore, that may overheat the testicles. And overheating, we know, can increase fragmentation in the sperm or reduce the quality of the sperm by increasing DNA damage. Kath, theoretically, yes, that may be a problem, but there are many people out there who do road cycling in lycra and have had lots of kids. So I wouldn't immediately get your partner to stop cycling altogether. I would probably do a semen analysis and maybe even check the DNA fragmentation. And if everything's good, then, you know, cycle away and stay healthy, because that's important too. Lucy has a question here, and it says, I have been told that ectopic pregnancies can be more common in IVF. Why is this the case? Actually, Lucy, that's an interesting comment. I have heard that mentioned too. However, if we look at the literature surrounding the topic, ectopic pregnancies are actually not more common in IVF, especially these days when embryo transfers are done with, you know, the minimum amount of culture media needed, with the catheter placed exactly where we want it, under ultrasound guidance. The risk of ectopic seems to be equivalent, whether we're doing IVF or whether we're conceiving naturally. And the risk of ectopic is probably in the order of 4%. So if you have had a previous ectopic before, and therefore you will have, even naturally, you will have an increased risk of another ectopic. And if your other tube is patent and someone suggests you do IVF just because therefore ectopics don't occur, then that's not accurate, because even with IVF, ectopics do occur. But these days, with you know, adequate visualization on ultrasound, with adequate catheter placement, one embryo transfer, you know, minimum required culture media, the rate of ectopic pregnancy seems to be very similar, whether it's natural conception or IVF. Rainbow, my husband has balanced translocation. Is NIPT test shows this translocation or other chromosomes? Rainbow, so going back one step, Rainbow's asking is if we have a chromosomal rearrangement in our makeup, then will an NIPT test show this translocation? So I suppose the first step is translocations are rearrangements in our own chromosomes, but that often means that we haven't lost or gained any chromosomal material. Therefore, for all intents and purposes, our body's functioning normally. So we may not know we have a translocation until we want to have children, or until we have recurrent miscarriage, and until we do a karyotype. Now, remember I said 23 chromosomes come from the egg and 23 chromosomes come from the sperm. So if you have a rearrangement in your chromosomes, occasionally that half set of chromosomes that you're giving is going to have the wrong order. Therefore, when the chromosomes come together with the egg and sperm, the embryo created is more likely to have a chromosomal error in it, and therefore end up in a miscarriage more often than in natural conception, where both karyotypes are normal. So how we normally counsel the patient is that the first step is actually maybe to consider genetic testing on the embryo. So we do IVF, we create embryos, and then we genetically test the embryos to find a balanced or normal embryo. But if you fall pregnant on your own and that pregnancy then is progressing, a balanced translocation will not cause it any issue, but a rearrangement on it or an unbalanced genetic situation will cause it to potentially miscarry. So the NIPT test is the non-invasive prenatal test. I'm assuming, Rainbow, you mean the test done on the baby, the fetus, at 10 weeks. So that means the fetus would have had to make it that far. A lot of unbalanced embryos that are not going to progress to live birth would have miscarried earlier than that. But if we are pregnant and it's progressing, yes, translocations that are unbalanced can, or even balanced, can be picked up on certain NIPT tests. But that is when you would be speaking to our genetics counselors, who will find the appropriate test for you and then decide if you needed a more invasive test like an amniocentesis to further delineate things. Navia asks, if one partner has vitiligo, does it impact? I had one early chemical pregnancy. Well, I guess, Navia, you mean that is an immune condition or an autoimmune condition in the dermis. So any kind of autoimmune condition may affect, or could affect chances, but I don't have any specific research to suggest that vitiligo actually does impact anything directly. So if the overall autoimmunity in a woman can sometimes cause this sort of pregnancy loss picture, needs to be further investigated. But if a male partner has it, for example, it normally does not affect the sperm and therefore does not affect the implantation. Thanks for joining us, Kelly. Thank you for coming in today. And Lucy says, I had an ectopic on my first of 6 transfers, but also know I am more at risk of having another. Yeah, Lucy, as I said before, ectopics are one of those things that a lot of the time you may have had completely normal tubes and no history of chlamydia or any other infections, and it just happens out of the blue because the movement in the tubes may not have been entirely normal, or the cilia may not be entirely normal, and there are a lot of things that we don't know about the chemical attraction of the embryo to the endometrium that may not have gone correctly, and therefore it might have stopped in the tube. And yes, that's why we say that if you've had one ectopic, you're more likely to have another. But if you've had a self-injectomy where you've lost that tube, then of course that tube's safe with regards to having the other tube working. And when you say you're having transfers, I'm assuming you're still having IVF, Lucy, then even though the other tube is patent, I would hope that your risk of a subsequent ectopic is like the general population, which is 4 to 7%. So I really hope you don't have another ectopic and we successfully get you through with an intrauterine pregnancy. So we've come up to about 30 minutes of our session tonight, and I hope I've managed to touch on a few different things. I think we've generally talked about miscarriage. We've talked about the terminology, of what each different stage means. I guess what I also wanted to touch on were maybe the common causes of miscarriage, because as we said, chromosomal error is the biggest cause of early pregnancy loss, and that's something you can't change, unfortunately, and it's nothing you've contributed to. However, if things are happening later in the piece, then we have to think about thrombophilias or clotting issues. If implantation is not happening, then your doctor will have to look at any structural problems in the uterus. Don't forget to look at your partner's sperm, and as we had a comment before, if things are still not happening, check the DNA fragmentation in the sperm. As Rainbow said, we need to check your chromosomes in yourselves, your karyotypes on both of you, to make sure that you don't carry any rearrangements. So if we've lined up that the eggs are okay, the sperm's okay, the structure's okay, the quality's okay, you're doing everything you can with lifestyle measures, the sperm quality's okay, then we've checked the inside of the uterus and it's okay, and less likely immune problems. And if we've checked those and they're okay, then remember we need to check the embryo, and the embryo also needs to be okay for things to happen. Now, once implantation has occurred, Amy Louise has asked if progesterone can help prevent a miscarriage. That is a very, very important question, Amy. We have seen that if progesterone is low on the day of embryo transfer, it does reduce implantation, and if we rescue that progesterone level, it does rescue the pregnancy rate. So in an ongoing implantation, adequate supplementation of progesterone may help progress things, but the data or research out on progesterone and its utility to prevent a miscarriage is grey, because remember, if the miscarriage is caused by an abnormal embryo, then there is no role for progesterone preventing that loss. So it's only of use in certain situations where there is a lowered progesterone, or where things can be supplemented to help. So certainly talk to your doctor about that if you feel that it's something we can help you with. And as I said, let's not forget our partners in all of this. There are siblings involved as well. And I think what we need to remember as a group is that we need to support each other, talk about pregnancy loss, not be afraid to tell your immediate support people. You don't have to wait till 12 weeks. Yes, the risk of miscarriage is highest in the first trimester, but once you've seen a fetal heart, that's lowered a little bit. And once you've done an NIPT test, it's lower again. You may not want to tell everyone till 12 weeks, but you may want to share it with people who are going to be your support. And if something were to happen, remember that it counts. Remember to validate your experience. Remember to take the time you need to grieve. Remember to let your caregiver or fertility specialist know, reach out for support. Our clinics have great counseling services, and we are definitely here to help you achieve that dream, because a pregnancy, no matter how early, has already opened up hopes and plans and futures that you've started thinking about a baby, started thinking about a future as parents. So it is a big thing. It is an emotional roller coaster, and just be rest assured that we are here for you. So I hope I haven't just taught you a few things about the causes and what we can do. I also want to acknowledge that it is difficult. Last thing I wanted to say is that in the past, people used to say recurrent miscarriage then warrants investigation. And by recurrent, I mean after 3 losses. But we are more and more coming to the realization that it's a difficult situation to be in, and it's devastating, and who wants to wait for 3 losses? So even if you have had 1 loss and want to look at investigations that may put your mind at ease, please come and see one of us and talk to one of us. If you do have a miscarriage and someone has suggested that we do so when you do have a miscarriage, you can either wait and see what happens and if you pass the pregnancy yourself, or you could take tablets to facilitate the process. And when you take tablets, that can cause cramping and pain, and you need to be prepared. The third option is to surgically gently evacuate the uterus of the pregnancy tissue. Now, if you've had 1 miscarriage, historically people do a suction curette and don't test the chromosomes in the products. I think we are now becoming more aware that if you are going to do a surgical procedure, ask for the pregnancy tissue to be sent away for testing, because if that comes back abnormal, it gives you some closure as to why that pregnancy failed. It doesn't leave you questioning if your body could have done better, or if your uterus did something wrong, or if you ate something wrong. It gives you a reason for why that pregnancy failed, and therefore it is very hopeful that it will not happen again, and that was a random chance. April, I think we're down to our last few questions. We already have a 2-year-old daughter conceived on the first try naturally, but have since been diagnosed as a carrier of an X-linked genetic condition. We have just had an egg collection and fertilization with PGS and PGD. So this is screening for the X-linked condition. We were able to have 5 embryos biopsied and frozen, but the biopsy results show 2 A-quality embryos, 2 which are affected, and 1 mosaic. So what are the risks of transferring the mosaic on having a healthy baby? Again, very good question, April. Now, mosaic embryos means that there's partial abnormality in the embryo. The first thing to note is we need to get you to speak to one of our genetic counselors, and they will go through this very thoroughly and clearly for you. And the decision is made based on what the mosaic problem is, because certain mosaic chromosomes are safer to use than others. The second criteria is how big the mosaic is, because the larger the mosaic size, funnily you would think the worse that is, but actually the better it is to use the embryo, because if it is going to be intact to implant, it's usually okay. And the third thing to take note is that if we do decide that it's a safe chromosome and the right size of a mosaic to then go ahead and have a transfer, if you do fall pregnant, then we recommend an amniocentesis during the pregnancy to then confirm that that mosaic or those mosaic cells were just confined to the trophectoderm or the cells that become the placenta, and it's not actually affecting the baby. So that's an individualized answer, I'm afraid, April, that we can definitely help you with one of our genetic counselors. Okay, so I hope I haven't bored you all. I've had a really nice time seeing all your messages, and I hope I've helped answering some of your questions. I will start wrapping up the session now, if I may. And I wish you all the very, very best in your journeys, and really hope you get to the successful outcome ASAP. Don't be afraid to reach out, to talk about things, and to ask for help. Take care, everyone. Thank you. And as I said, come online and have a look at our resources that we have on there for you. And it's been my pleasure. Take care. Good evening. Sonia, should I quickly answer that one? I think Sonia just snuck in. It says, how much do natural killer cells affect implantation, and should Clexane be taken prior to implantation? Sonia, natural killer cells is a massive topic. It is part of the topic, as I told you, that is in immune medicine, which is rather controversial because of the lack of large randomized control evidence. However, if you do have natural killer cells that have been detected, speak to your specialist in conjunction with your history, and if everything else has been ruled out, we should definitely consider therapy in an individualized situation. So if you have a borderline result, then we may suggest Clexane or doing a uterine killer cell if you've only done it on bloods. If you have all parameters elevated, we may consider steroid therapy and Clexane. But again, it is an individualized approach based on the parameters that you find abnormal and how abnormal they are. So there you go, Sonia, just snuck in there. Have a good evening, everyone. Take care. Thank you. Bye.